what's happening on the many frontiers in radiation oncology, whether it is in the radiobiology side, in the physics side, and also in the data sciences side. And I hope I can do a good job summarizing all of these advancements. Well, starting with radiotherapy outcomes, these are typically defined by the tumor control probability, TCP, which is the probability of local control given a planned dose distribution, normal tissue complication probability, and TCP, which is the probability of some defined side effect on the patients due to radiation. For a good plan, typically we would like the TCP to be higher than 50% and the NTCP to be restricted within 5%. This is a famous figure that goes back to the 30s, showing the relationship between TCP and NTCP. Interestingly enough, both have this kind of a sigmoidal type shape where it increases and actually it hits a plateau. And what we would like with the TCP and NTCP to be separated from each other as much as possible. So this is pretty much the goal of radiation oncology, and that's what mathematical modeling try to achieve. Some metrics could be used in that regard to aid in this process, such as the complication-free tumor probability, which is sometimes referred to as the P plus, the TCP minus 1, and TCP as one way of achieving that. I'll touch base back into this metric again. So in terms of modeling response to radiation using mathematics, the idea is to combine mathematics with physics and, of course, biology and computer science to study the behavior of tissue in response to a radiation. The objective from these studies is to make a prediction about what will happen in the patient in terms of the TCP and NTCP that's being treated in response to changes in the radiation conditions. This is a textbook that I'll be probably referencing throughout this presentation that gives you a guide for modeling, specifically in radiotherapy as well as in the more general realm of oncology. Now, what can be achieved in mathematical models is actually trying to model what's happening in the real world. So there are these observed clinical outcomes, and we try to come up with mathematical model as a representation of these. There are actions that usually take place in terms of treatments, and there are these observed outcome. And you try to compare the prediction of the mathematical models with the actual observed outcome and try to match these in a more or less an iterative and a feedback type loop. Just a short background on some of the basic principles of radiobiology. As you know, many of these stems from cell culture and in vitro assays, showing the response of tumor and early tissues compared to late responder. Luckily, in radiation oncology, there is this window of opportunity here between these two curves when you are looking at these clonogenic assays. And it's actually peaks here around 2 gray, more or less, and this became a standard fractionation, as you know. There are two mathematical models that evolved in order to describe this kind of response. One of the earlier one is called the multi-target single hit, and as we know currently, the main target for radiation is probably the DNA, and more recently there were actually other targets. This is a single exponential type response, distinguishing between the high LET linear energy transfers and low LET, which is typically what's used with electrons and photon. The other model is the linear quadratic models, that is a double exponential that looks at the radiation sensitivity effects in terms of this alpha beta ratio. I know that there is another lecture with Dr. Yavash discussing this one in more detail. So I'll just briefly, just for the sake of discussion, touch on it. It's also, again, can distinguish between low LET and high LET. Radiation biology is typically defined by the 4 R's or the 5 R's as shown here, which is trying to factors that lead to increase in the survival fractions, such as repair and repopulation, and factors that are actually helping us mitigate clonogens like reoxygenation and reassortment, the sensitivity during the cell cycle. The fifth one is typically the radiation sensitivity that can be prescribed by the alpha beta ratio. So a little bit more about the linear quadratic models. Most of its current reincarnation is based on the work of Professor Fowler's, which pretty much described by two terms, the alpha term and the beta term. The alpha term represent a single hit, while the beta term represent the double hit effects, and it's actually implies the repair capacity of the tumor, the tissue that is being irradiated. And we can distinguish between responses low LET and high LET, although the most focus here is going to be at the low LET. Now, if we look at the survival fractions, it's going to be given by this formalism. It's an exponential formalism with first order factor and the second order. And you can see there is another adjustment factor called the catch side effects that is mainly related to those rates. So typically in a linear accelerator, this is set to be 1, but when you are dealing with a lower dose rate, like in brachytherapy, it's between 0 and 1. Now, the tumor control probability can be described as a Poisson phenomena using this exponential relationship, and here would refer to the number of clonation and giving the survival fraction there based on the sensitivity parameter, the alpha-beta ratio. We can actually predict the TCP using these techniques. Now, a related metric is the biological effective dose, and that metric helps us in transformation between different fractionation type effects. It's a theoretical metric where assume the fraction size is actually infinitesimally small. Then there are two parameters associated with it. The relative effectiveness, which is this component here, which is the fraction size divided by the alpha-beta ratio, and it's actually modulated by the total the total dose number of fraction multiplied by the dose per fraction. As I mentioned, this is a very useful parameter when looking at trying to compare different fractionations with different alpha beta ratio. So this is a standard fractionation here, 60 gray, showing you for the early tumor response, the effectiveness, the BED would be about 72, and for the late tissue would be around 100. Contrast that for hypofractionation or SBRT fractionation, shown in this case, 3 fraction 20 gray, and you can see that the BED is actually much higher. Now, this is a non-physical phenomenon. In order to have a physical metric, there is the equivalent dose, and typically is referenced by the 2 gray per fraction standard, and this will give us a metric that is more physically interpretable using this kind of ratio based on the BED transformation. Now, once we are talking about these type of models, at least from the analytical perspective, hypofractionation represent another case where the LQ models with the fraction sizes above 5 actually did not provide good performance unless the alpha-beta ratio increased to non-theoretical values as shown here. So this is typically what's the LQ model is going to predict, and this is actually what's being observed. So it's overestimate the beta effects. In order to correct for that, there is a combination of the multi-target single hit and the LQ model called the universal survival curve, and different variation on the LQ model in order to account for hypofractionations, including the LQL type techniques, and you will hear later on more details about these. Now, SBRT has garnered a lot of interest because it actually goes against some of the theoretical foundations of standard fractionations in terms of early and late tumor response, but there is a geometrical factor associated with that that can potentially explain why these models actually perform to the degree that they perform. And there are adjustments, as I mentioned, whether using the USC or using the LQL type techniques. Now, another observation with the interest in immunotherapy is the role of radiation in instigating immunomodulation based on, as we know currently, based on the gases signaling pathway. In this case, radiation is acting actually as a vaccine and complementary effects to immunotherapy. And this is an area of interest, and our modeling schemes need to adjust in order to account for that as well. Now, asking another question with regard to particles, starting by proton, carbon, and so on. And as we know, these particles exhibit what's called the Bragg effect. And in this case, there is no exit dose, so essentially there is better sparing of normal tissue. But when practically applied, there's the spread of that Bragg peak. And this is actually lead us to investigate what does the radiobiological effectiveness as a function of LET. And we can see it actually varies across that path at reaches its maximum around the Bragg peak. And this is showing different RBE there as a function of energy, example for particle therapy compared to photon standards. More interestingly, when doing treatment planning with heavy particles, there are values that's actually being used. And these values about 10% increased in the RBE value. They are arbitrarily set, and currently there are investigations how we can incorporate LET better into planning. More interestingly, it's not only related to the physical phenomena associated with LET, but also a more recent investigation showed that heavy particle response, depending on the density of the tracks, actually may result in variation in gene expression and signaling pathway that's different just from the physical phenomena associated with the representation of particles, including proton and carbon. And that's an active area of research as well. Now, of course, the discussion won't be complete without talking about the flash, touch base on the dose rate effect. But more recently, there has been interest in this ultra the highest dose rate effect called the flash effect. And the idea here is that once using this very high dose rate above 40 grains per second, it's actually spare the normal tissue, as if the radiation become transparent to the normal tissue, while still maintaining same effectiveness with cancer, which is quite surprising results, and pretty much breached that dogma of separating the TCP and NTCP by modification of the dose rate. There is a lot to be understood with this phenomena. Currently, it's being related to oxygen depletion, but other factors may play as well. These are examples from a preclinical study using a cat model as shown here, where the cancer, the nasopharynx, was cured while little effects on the normal tissue. Also using a pig skin, you can see this is the conventional radiation leading to injury, while the flash radiation became transparent. There has been also a clinical case for a patient with a cutaneous lymphoma shown here, and the radiation was prescribed about 15 gray with a 5.6 MeV electron linac, what was delivered in 90 milliseconds. Given the very high dose rate of this radiation, the patients actually observed a blue flash, which is Cherenkov emission. And you can see there have been sustainable tumor response while limited normal tissue toxicity despite the very high dose and dose rate as well. So there is a lot to be understood about this phenomena as well, and mathematical modeling can help in that regard. Now, in terms of what are the schemes that are available for outcome modeling, there is the top-down approach, and there is a bottom-up approach. In the top-down approach, the clinical endpoint is actually related, the starting point, and we relate it to the physical phenomena or the genotype. In the bottom-up approach, you start with the genotype, and you go to the physical phenomena. Most of our work here will focus on the integrated type modeling approach versus the first principle mechanism, which is more widely currently used, and of course would involve newer techniques like machine learning and AI as well. So in the integrative radiobiological modeling, the idea here is to think about TCP and NTCP as multifactorial. They don't only depend on the radiation dose, which is historically what we've done, but also on patient characteristics, including the genome, which is called an area called radiogenomics, as well imaging information called an area called radiomics. So our TCP and NTCP metric, including this P plus metric, are function of the damage metric, which combine those with other available omic information. So looking at radiation therapy as a big data or a pan-omic type approach. Now, in this top-down approach, when modeling TCP and NTCP, need to distinguish between analytical type techniques. Some of it are mechanistic, like the LQ model. Some of it are phenomenological, like using AUD, equivalent uniform dose. This is when dealing with hotspots or cold spots. Now, the most focus currently has been on data-driven type techniques, using simplistic regression model, such as logistic regression, or more advanced machine learning and AI techniques. And I will discuss more about these. However, before getting into more details, I would like to highlight there are actually software tools, like this software tool that we developed several years ago, that actually can be downloaded from this website and would allow you to conduct analytical as well as basic data-driven type techniques. One example using regression type techniques is trying to identify what are the optimal parameters when trying to look at radiation pneumonitis, for instance, and what are the metrics that drive this kind of model, such as location in the lung, maximum dose, or the D35, for instance. Now, talking about more advanced NTCP modeling, like you're doing radiogenomics, where you are combining not only the physical factor, but also including the genetic factors, such as genetic variants, and trying to identify low risk and high risk patients. I'm going to show an example for rectal bleeding and prostate cancer. And in this case, we are modeling using the Lyman-Kuchar-Berman model. I'll discuss more about these when talking about the normal tissue and toxicity modeling in the next lecture. But here you can see that with this NTCP model, as a function of dose or equivalent uniform dose, this is the kind of the prediction you get. Now, if you include the genetic factor, and in this case, looking at copy number variation or single nucleotide polymorphism, you can see for some patients who exhibit this kind of variance, the risk actually increased almost double for the same dose that's being delivered. This is using the LKB type model, and this is using a regression model. And from the regression model, you can see the fit for the data is actually better compared to using the symmetric type techniques, although the dissymmetric techniques are also still important in the modeling, but the copy number variation, which is the XRCC1 here, would actually add significant sensitivity to the model, improving its performance. Another aspect is not only looking at the genetics, but also looking at the protein profile. And we know the protein profile is important when looking at normal tissue toxicity and inflammatory response. This is an example looking at liver function. And the endpoint is looking at changes in albumin and bilirubin as how the patient liver function changes after they receive radiation. Some of the cytokines that were extracted and analyzed in this study are the TGF-beta, iotaxin, the hormone growth factor, and the CD factor ligand. And these were analyzed using ELISA assay from blood samples and incorporated into the mathematical modeling. So this is the dissymmetric NTCP model, again, using the LKB, and this is its actually prediction as shown as a function of the mean liver dose. Now, endpoints play a critical factor here. So instead of LB, one can actually use Child-Pugh, which is quite similar to the LB in terms of performance, or using enzymatics. And the sensitivity of the model actually will change depending on the endpoint that is being used to define the toxicity, in this case, liver function. So what's the impact of adding additional information to the dissymmetric model? In this case, we're using what's called the parallel architecture model. I'll explain these in the next lecture when talking about normal tissue. Perfusion imaging based on MRI is being incorporated in defining what's called a damage model for as a function of the dose that's received by the liver. These are the changes in perfusion that's being observed, adding to that model as well as the cytokine. And you can see the sensitivity of the model changed dramatically from being a shallow model as a function of dose only to being a much steeper model as a function of some of these cytokines, in addition to the imaging information, which is changed on the TGF-beta factor. So addition of this information will make the model more sensitive, more accurate to fitting the data. And this is using a variant on the analytical type techniques. Now, more advanced techniques, I'll touch base on some of the machine learning approaches that can be used for the same purpose, which have better ability and capacity to integrate information compared to more traditional type methods. So in this case, you have a different factors, genetic variant, gene expressions, imaging information, radiation, and you can use conventional machine learning techniques. These are called Bayesian network to do a feature selection, then build on a hierarchical model showing the relationship between the different variables. This is an example application in lung cancer, showing the relationship between the genetic factors, between including the cytokines, also including imaging information, the radiomics, and the change in these features as a function of those factors and how they impact local control and radiation pneumonitis. Now, for comparison purposes, looking at this accuracy metrics, here you can see with those only metrics, you get about 63% accuracy. Adding these other factors using the Bayesian network, you can get 80%. And if you include the changes during therapy, then you can get up to 85% in terms of accuracy. Now, as I mentioned, we can use imaging information for predicting response, in this case, looking at survival in liver cancer in a field called radiomics. And you can see using these deep learning techniques, you can distinguish between patients who are at higher risk from death from patients who are at lower risk from death. Now, deep learning techniques can also be applied for a multi-objective and a multi-omic approach as the previous conventional machine learning techniques, but in this case, you can feed the raw data using different architecture, whether it's the convolutional neural networks or autoencoders in order to make sense of that kind of information. And if you look at the prediction of this kind of composite neural networks compared to some of traditional Lyman type models, there is significant improvement in terms of performance, whether predicting toxicity or predicting local control. More interestingly, in these models, you can also look at the competing risk between local control and toxicity all in the same setting. Now, having these models, what next can we do with it? This is an example from a prospective study that's done for adaptive therapy, looking at pre-treatment PET and during pre-treatment PET, in addition to the other genetic and protein profile, and try to develop a decision support system for predicting what changes in fractionation for those escalation need to be applied once observing changes on PET images. And you can see the computer prediction that's in solid line and the original clinical decision that were made in terms of modification. They more or less agree in terms of performance. Green meaning there is an improvement, whether it's local control or reduction in toxicity. Red, there is actually a risk, and orange, there is no change. However, when you reach actually more cases over time, you can see the physician is actually not exactly following the protocol, while the computer is being more conservative, but also taking risks. So that's kind of a distinguish between a computer being more conservative, while a human could be more creative in their decision-making process. Now, I will touch base shortly about the bottom-up approach, which is using basic principles as modeling criteria. And this is start to modeling the physical interaction of radiation. Next stage is the chemical interaction, then the biological effect from the bottom to the top. As we know, radiation interaction actually is variant in terms of time and space. So energy deposition can happen with the radiation interaction using X-ray, electrons, or you name it, within femtoseconds. Then there is a chemical stage where free radicals are actually being generated due to these interactions, and these ions actually are responsible for the indirect effect primarily of radiation. Then there is the biological phase, which is actually the most complex phase that involve DNA damage and repair mechanism. This can happen at the molecular level, cellular level, or tissue and organ level. And of course, as we know that tumors are not homogeneous, but also heterogeneous. So there are many factors that could be involved in developing such technique. Now, this is an example from Dr. Benson showing how this works out in terms of radiation-induced fibrosis. After the radiation interaction, there is some activation of molecules such as the TGF-beta, and there's the injury and the injury repair, which takes time, days, and as well as can take years. So to recap, in order to be able to do this kind of bottom-up type approach, we use Monte Carlo techniques given the complexity of these approach techniques. And we use what's called track structure type Monte Carlo code. And it's divided into three phases: the physical phase, the physiochemical phase, and the biological phase. In the physical phase, what these methods actually try to estimate is the damage in DNA, whether single strand breaks or double strand breaks in terms of giga base pair per gray, and what are the subsequent processes. And there are many software tools and code in order to model, especially that physical phase. I'll highlight some of these software. The most commonly used, which is an open source, is the GN4 DNA, but Quadratic is actually one of the advanced, more advanced type softwares as well. These models and software shows you the different mechanisms that are involved, whether it's excitation, ionization, or elastic scattering. And the different codes have different models applied, and that's why you can see different prediction associated with these models. Showing a GN4 example where the different processes are selected, different modeling scheme for the different interactions. And you can see the performance as a function of energy in terms of the prediction power associated, what are the probability of interactions that can vary depending on the selection of these models. This is to say these type of models are very parametric, and the selection of the different models and their parameters actually play a major role on what's the expected results from these techniques. After the physical stage, there is the chemical stage, which is pretty much is the ionization stage, where generating of free radicals, which actually run such as, aqueous electrons or hydroxyl ions roaming around, and this can take up to 1 microseconds, and the process itself follows a Brownian type motion. Now, after that stage comes the most complex stage, which is the biological stage. And the biological stage involves, after the physical and the chemical stage, a radiation sensing process, like we know the ATM, ATR being involved in that process. And there are multiple things that can happen: cell cycle arrest, DNA repair, apoptosis. So some of these codes that I mentioned, such as the Quadratic, for instance, have models for the DNA repair, whether it's using homologous recombination or non-homologous in joining. And you can imagine how complex these type of approaches and the number of parameters that can go into it, as well as to that our limited knowledge. So makes this type of modeling quite more complicated than the integrative type approach. This is an example from our work showing what's the DNA yield for this case. So this is a typical GN4, just a standard one showing you ionization, and this is the GN4 DNA, which has a model for the DNA structure, the double helix. And these models, you can actually define the different parameters depending on which DNA structure you wish to choose. And this is showing the DNA damage yield, whether it's a single strand breaks or double strand breaks, for the different DNA structure models by some of the work we've done, some of the work in Quadratic, and some of the work in GN4 as a function of the incident energies, and as a function as well as in the parameters that are used in these models, whether they are threshold parameters and so on. And this can actually get a little bit more complicated when you are using particles. Instead of electrons, you are using proton, helium, lithium. And you can see there are different models give you different predictions. And when you start to compare it with experimental results, depending on condition, you can get more variations on these techniques. So there is need for some form of standardization when applying these approaches. Ideally, what we would like to have is a bottom top and top bottom, where information from the track structure modeling techniques can help the integrative models, and the integrative models, whether using analytical techniques or more advanced machine learning techniques, can help optimize our estimate of TCP and NTCP. And in this cartoon, we're showing some of the steps that are required for the validation of this kind of composite type approach. Now, some of the take-home messages that I hope I was able to convey, there are two types of radiobiological modeling frameworks. One is an data integrative one using system biology techniques. That's a top-down type approach. The other one is use first principle models with numerical simulation, primarily Monte Carlo type techniques, and this is a bottom-up type approach. In the data integrative models, combine actually the radiation physics with the biology, that could be genetics, or could be protein expression, and you name it, or imaging information, radiomics, to enable better prediction of radiation response, the TCP and NTCP. And this can also help with the personalization of treatment as well. However, these type of approaches have limited mechanistic understanding, although there are advances using more explainable or interpretable type approaches, such as the Bayesian network is one example, or looking at the deep learning and try to understand how these algorithms actually function. On the flip side of that, there are the Monte Carlo track structure techniques, which is the bottom-top type approach, which can have direct implications for mechanistic understanding of radiobiological mechanisms. However, there is a lot of assumptions are made when developing or applying these type of techniques. Now, the relationship between the top-down and the bottom-up still needs more exploration in order to optimize our TCP and NTCP modeling prediction, as well as our understanding of the mechanisms that are involved in radiobiological response. And I would like to share with you some of these publications and leave you with this quote from Madame Curie, one of the founding figures of our field. And thank you for your attention. Be happy to entertain any question you may have.
Thank you very much for this very brief and interesting lecture, Issam. Before looking to the chat box, I have two questions. Can I start with my questions first? Maybe it's a very simple question, but why we cannot reach the zero level on survival curves? We can achieve the cure in clinical practice, in daily clinical practice. As you know, we're medic people. So how can we explain this from a perspective of mathematics and modeling and radiobiology modeling? Can you have any comment?
Yeah, I mean, that's a great question. And if I understand you correctly, the definition of the clinical endpoint has been always a challenge. These models are as good as you define the clinical endpoint associated with them. I mentioned, for example, for toxicity, you can use, for the liver case, I mean, you can use LB changes, you can use enzymatic changes, you can use CHA2, and so on. In terms of tumor control, there are two, depending on the definition you are using for tumor control. If you are using the RECIST criteria, for example, for a stable tumor,